Thank you for that outstanding presentation, Dr. Methencourt. Now I'll invite Dr. Elizabeth Rebello from Texas. Dr. Rebello is a professor of anesthesiology and perioperative medicine in the University of Texas, MD Anderson Cancer Center. And as we're all aware, that's a huge place with lots of complex stuff going on. She's also a pharmacist by training and has been involved in patient safety for over 15 years. She serves as the past chair of the American Society of Anesthesiology Committee on Professional Diversity and also the past chair of the ASA Quality Management Committee, which is also a huge committee, and actually led a medication safety work group for them. She is the current chair of the ASA 2025 annual meeting committees. That's also a huge responsibility. 20,000 people attend that meeting, so it's huge. A lot of work. I don't know how you do it all. And also serves on the board of the Anesthesia Patient Safety Foundation. So we're really excited to have you here today and talk about medication safety in anesthesia practice. I always tell the residents there's always a drug error happening in an OR every single day. It's just we don't recognize it because sometimes it really doesn't impact the patient that much, but you should be aware of it. So please educate us. Thank you.
Thank you, Dr. Sundar, for that introduction, and I want to thank you all for giving me the opportunity to speak to you today on a topic that is near and dear to my heart, and that is medication safety. And I'd like to first begin by stating I have no relevant financial disclosures. And, medication safety is a huge topic, and what we're going to focus on today is really kind of three big areas, and that is labeling and how labeling can contribute to medication errors or help avoid them. Having standardized concentrations for high-risk medications, and that helps in terms of incorrect dosing and the error that occurs with incorrect dosing. And then lastly, talk about human factors and some of the things that we can do in terms of feedback mechanisms and constraints to decrease the incidence of medication errors. So let's begin. Of course, I want to begin with a story, and this is one when I was a resident over 20 years ago, and I was at the VA in the holding area, and there we had little curtain bays between our patients, and next to me there was a patient that inadvertently received, it was an amber bottle of a medication, a vial, and what was thought to be midazolam was rocuronium. And the attending anesthesiologist who inadvertently administered this recognized the issue immediately, grabbed an ambu bag the patient. The patient went to the operating room, and there was no untoward effects because of that recognition, to Dr. Sundar's point. However, many times that's not the case. And of all medical errors, medication errors are the most common. And this injures more than over 1 million patients per day with a cost of over $40 billion. This is not just the perioperative, this is medication errors overall. And it's interesting to think about, why do we see medication errors happening in the OR? The normal checks and balances that exist in the inpatient area involving pharmacy and nursing and such don't happen in the perioperative environment. And I would argue that, not only in the perioperative environment, in the OR, but in the Neuro space, you'll see because of the factors that Dr. Methencourt talked about in terms of maybe lack of familiarity with the team that you're working with, different location. The orientation is different every single time. Sometimes in the same day you're in the same area and you have to still move things around based on the side of the side of that they're intervening on and such. There's lack of standardization in the perioperative environment, and then again communication failures that occur. And then also, lastly, the severity of the errors that can occur. Because we give medications, we do all of those steps that have the checks and balances. We do them without those in the perioperative environment. So medication safety has been a really important topic for the APSF, and this just here highlights the top The top items highlight the articles that have been published in the APSF newsletters. And there have been 3 previous conferences focused on medication safety. And then most recently, the 2024 Stolting Conference was focused on medication safety and opioid safety. And interestingly, this is all available online. There's actually recorded sessions on the APSF website. We've had FDA, ISMP, and a lot of stakeholders from industry and other areas to help us work on this problem together to mitigate medication errors. Interestingly, I was invited last month to an anesthesia think tank, and this was actually created from the Stolting Conference. 2 of the speakers that worked together, one is G. Varghese, who's the pharmacy manager at Texas Children's Hospital, who works with Dr. Lauren Lobow, and they actually invited those, including robotics, to think about how we can make medication safer to administer. And one interesting thing that happened at the think tank was using robots to waste medications in terms of the controlled substances when there is not someone available. And so that may be something that we see down the line. I just wanted to share that with you as well. So let's talk about medication errors. Studies have shown that with observed studies, it can occur in 1 out of every 20 administrations. Now, not all of these lead to patient harm, but that is the observed error, which is actually translate to almost every other case. And I really want to focus on 2 types of medication errors, which are the most common. Incorrect dosing, which is why having those standardized concentrations are so important, and substitution, which is why having properly labeled medications, and I would argue color-coded labeled medications, are extremely important. So this study here, and I don't expect you to read the text, but this is actually from the Spanish the Spanish Medication Incident Reporting System over a 10-year period. And when you look at the 4 phases of the medication process, and that is prescription, preparation, dispensation, and administration. Administration is not only the most frequent error that occurs, but also has the highest harm. And you that work in the operating room know why. And then let's talk about the Neuro space. Again, there's a higher incidence in terms of death in neuro settings, as Dr. Methengool had spoken about, and the medication-related claims were 6%. I think about our practice at MD Anderson, and we talk about, being in a basement, but we actually have neurosites that are a mile away from the hospital. And so if you think about all the issues with medications and how far that can be, you can see how this incidence, is something that we all need to be aware of. So let's focus on that first big topic. Let's talk about labeling. And I want to focus on something about the labeling of a syringe and how labeling of a syringe from a manufacturer versus a 503B compounding pharmacy and a vial all appear different. And that actually may contribute to medication errors. And we'll also focus a little bit on color coding as well. So the ASA, most recently in 2020, revised the statement on labeling. And this particular document follows the ASTM recommendations in terms of color coding based on class. And I wanted to just show you here, why is it that when you're working in the preoperative environment, why do your syringes look different? Well, the top figure, the one with the red and white syringes, hexanocholine, have 2 different ways of how the medications are labeled. The top has the total strength of that particular syringe, 200 milligrams, in the total volume, 10 cc's, as the most visible on that label. And that involves a mathematical calculation. If you need to give a patient 60 milligrams, you actually have to think about that, calculate it out, and do it. It's one step. Versus the syringe below, the one in white, more prominently has the 20 milligrams per cc. It's a little bit easier to think about in a pinch for time how to dose that medication. And so those medications that are produced from a manufacturer, which have a 2-year expiration date, are required to have the total strength over the total volume, where those from a 503B compounding pharmacy actually can do either or. And this is all regulated by the FDA. APSF did a straw poll a few years ago to see what do we, anesthesia professionals, prefer. And the overwhelming majority was we prefer the strength per cc. That way we can do the calculation quickly and give the medication, the appropriate dose quickly to our patients when they need it. And so this is just the demonstration of the guidance for both the manufacturers and the compounding, the 503B facilities. And the FDA actually recognizes that the difference in strength expression does contribute to dosing errors. So they are aware, but we also need to help engage them further to think about how we can make medication administration safer to our patients. So the USP, the United States Pharmacopoeia, is a standard-setting organization, and they actually produce chapters. And chapters below the number 1,000 are mandates. Chapters above are recommendations. And Chapter 7 actually addresses labeling. And the USP recognizes that although everywhere else in the hospital, the strength per total volume should be the primary and prominent expression, there are exceptions, and those include medications such as insulin. It would make no sense to have the total strength of insulin over the total volume. You can imagine, I'm sure most of you here in the audience, they've either had or have heard of in your practice a medication error related to insulin overdose. And so these diagrams here just kind of show the difference of how it is, when you have a vial, you have to actually divide that out to calculate how much medication you're giving. And yet you see with insulin, there's an exception. It's the 100 units per cc versus the total volume. And then with local anesthetics, the option exists one way or the other. So now let's focus and think about color coding. And there's been articles kind of pro color coding, against color coding and such. And if you think about it, what do you hear? Oh, just read the label. When you think about just reading the label, sometimes we read something, but actually what's in our mind is something different. And how many of you are familiar with stop signs? What color is a stop sign? Red. Why is it red? It's red because when stop signs first existed, they were actually white. And people were not seeing the sign because they could just read the sign and go on. No, it created accidents, and so they actually changed that to red, noticing that there was a change in the 1940s, by having that color as an additional incentive for us to look and stop before we proceeded. And you can make the same argument with street lights as well, the red, yellow, green. And so even though there's been an argument against color coding, and there are people that are colorblind, by and large, having color actually helps us make decisions when needed. And so the ASTM is one of the organizations that actually provides guidance for the user-applied color-coded labels that we have in our operating room. And they published the standard in 1988. And in 2022, the standard was withdrawn. And it wasn't withdrawn because it was ineffective. It was because the ASTM actually sells the standards to companies that make these labels. And it wasn't really revenue generating at that point. But having the same type of color label, does promote error. In addition, having what we normally know as the appropriate color for a certain class when it's a different medication also could contribute to an error. So here you see the red labels for ondansetron. Well, red, in our environment is associated with a neuromuscular blocker, and then so you can see the potential for error to occur. So what's happened since 2022 is APSF and ASA has advocated for the standard to be reinstated, and thanks to Dr. Richard Botney's efforts, the standard actually was reinstated in 2025. Now let's focus and think about vial tops. How many of you have worked in your operating room and grabbed a vial and looked at it and said, oh, wait a minute, that's not what I thought it was? I want you to raise your hand high. Okay, that's the majority of the audience here. And so it gives me pause, both as a pharmacist and anesthesiologist, when I see that fourth medication, phenylephrine. Because if you give that vial of phenylephrine, 1 cc to a patient, expecting any of the other medication to be given, severe patient harm can occur. And I would argue that if there's one medication to have as a prefilled syringe in your perioperative environment, it's phenylephrine. And that's because in that one vial, you have 100 times the standard dose, right? If you have that vial, you have to dilute it and then dilute it again, double dilute it. And there's obviously issues with that related to medication errors. And so it's important, as anesthesiologists and anesthesia professionals to advocate for prefilled syringes, especially with this medication because of the harm that can occur. And so APSF has created, a library of look-alike ampules and vials. And if you see these when you are practicing, we have actually the next slide shows the site you can actually submit to. But one thing that I also caution against is that look how similar, this is something actually from my institution recently within the last few months, where the lidocaine and ondansetron, they look so similar. Whoever was restocking that, because their human error occurs, put that there. And so that's something that we all need to be aware of. So when you see this in your practice, please go to the website, submit these, because it does two things. One, it helps educate, but two, it also helps us advocate against that and maybe towards having color-coded vial tops based on class of medications. And if you think about it, this is not only in anesthesia. The ophthalmologists have the same issues, and the American Academy of Ophthalmology actually advocated, and if you think about eye drops, the top of the eye droppers, the vial, the drops are actually color-coded based on class. Now, eye drops have a smaller market compared to vials, but it's still important that I think we advocate for the high-risk medications, the opioids, the pressors, the muscular blockers, for color-coded vial tops to help prevent medication errors from occurring. And we're not limited to just vials. In addition, we also have issues with ampules. This was actually it was a cardiac case in which, as the patient was being intubated, rather than expecting the normal occurrence when a opioid is given, the patient's blood pressure and heart rate was elevated. And when someone looked into the Sharps container, they noticed that in a place of sufentanil, epinephrine was given. And that was recognized again, but this again is a common error that occurs. Another common error that has actually been increasing of late in the last few years is the wrong drug, wrong route error, and that is tranexamic acid being given in place of bupivacaine. This particular article here highlights 20 cases in which 10 patients died from receiving intrathecal TXA. Since then, in 2023, there was another 22 reports that occurred. And so this particular error is on the rise. Why? Because it's high production pressures, these medications look similar, and there's several examples of similar medications that occur. So in the June of 2024, we published this multi-stakeholder perspective involving attorneys, industry, ISMP and such, and said, how can we create a way to make this not happen? And the recommendation was not to have TXA vials within the perioperative environment. There's 3 ways of being able to prevent that. 1, you can get a premixed bag from the manufacturer. 2, have a 503B compounding manufacturer make it. Or 3, have your pharmacy have the vials there, make a bag, and bring the bag. And then recently, if you use TXA routinely, another option is to have oral TXA and give the patient that in the holding area prior to, if you know in advance you'll be giving the patient. And this is relevant for orthopedic procedures and such. Just wanted to share that bit of information also. Now, let's switch gears and talk about standardizing drug concentrations and why this is important. This is an old study from 2008. In this study, they actually surveyed pharmacy managers and asked them what the concentrations what they had at their particular hospital locations of these high-risk medications. And the number was startling. I want to alert your attention to that column. For phenylephrine, there were 45 different concentrations of medications. So you can see why, when you look at this list here, these are medications that we give routinely in the perioperative environment, right? Insulin, midazolam, phenylephrine, epinephrine. And so this is something to be aware of. And it's important that we, as anesthesia professionals, work with our pharmacy and limit the number of standardized concentrations that we have in our environments. And so really this whole concept of standardizing concentration really means looking at your patient population. You may need a pediatric set as well, but rather than having 6 concentrations of a medication, reduce that number to decrease the incidence of an overdose from occurring. And so the ASA had a work group with several representatives from several committees within the ASA to focus on which 10 medications should be standardized based on closed claims data and such. But it's not just anesthesiologists that advocate for standardization. Most of you are probably familiar with Dennis Quaid. His twins, when they were born, received 1,000 times the dose of heparin each, twice. That was 4 medication errors that occurred. Luckily, nothing happened long term, but he actually advocated for medication safety for his children after that event occurred. And so as you can see, the goal of standardization is to decrease that variance, and we should be involved. And really partnering with our pharmacists and pharmacy department is a really important part of that process. So this is actually a slide from the Stolting Conference. One of our presenters presented, and this is just a picture of the different concentrations of heparin that exist. You can see why a medication error is so easily done because of the wide number of concentrations that exist and the importance of really decreasing that in the location where you practice. And so the ASA in 2019 actually has a statement with recommendations on standardizing these concentrations. And so I encourage you all, when you go back home, find out if you have standardized concentrations and the number for those 10 high-risk medications. These are the recommendations from the ASA. I just wanted to share that with you as well. In addition to medications, the vials, another issue is pumps. And in this 7-year period, there are over 50,000 adverse events with pumps. The Remedy database was created to try to integrate all pump-related data and try to present some recommendations there and some publications. This was through Purdue University, but with the pandemic in 2020, that was sunsetted. And so really it's up to us to work with our pharmacists again, not only with standardizing the concentrations of the high-risk medications, but also to inquire about pump data and see about also having those medications standardized as well within a pump to help avoid issues with dosing errors related to the pumps. And then lastly, I want to focus a little bit on human factors. When you think about the anesthesia machine side of anesthesia and the medication side, there's such a disparity in terms of safeguards that exist. For the machine side, we have the color-coded gas lines, we have the diameter and pinned index systems, there's many alarms that go off, we have waveforms and everything. But on the medication side, there's really no way of really checking a dose, and there's no alarm that goes off if an incorrect dose is being given. And so there's 2 types of mechanisms that do help us, and that's feedback. And with feedback, we are given information, and that actually means something to us. And then there's constraints. And constraints actually prevent us from having an error occur. And I think about the fence and that tennis ball. And a constraint actually is avoids the tennis ball from going to the other side. So some examples of feedback are the color-coded syringes, but they mean something. The barcoding scanning, having labels and such. But there are workarounds around feedback. Generally, with constraints, it helps prevent that from occurring. So a constraint is more effective, but they are both important. And so this is just some examples of the constraints that exist. And then I want to go over just the process and how one example of a constraint. So on the previous slide, there was a prefilled syringe. And just having a prefilled syringe eliminates the entire preparation phase of the medication delivery process. And by doing that, you actually eliminate 6 of those blue sub-steps and 19 possible failures that can occur. I'd love to see in the audience here, how many of you have pre-filled syringes where you practice? Raise your hands. I'm just curious to see where we are. Okay, so it looks about a third or so. Prior to the 2024 Silting Conference, we actually polled those that attended the conference, and we were close to about 40 to 50%. And it's interesting because in 2010, when the APSF had a medication safety conference, prefilled syringes were recommended, but the utilization of prefilled syringes at that time was like between 5 and 10%. So over the last 14, 15 years, we've actually made some progress with having more prefilled syringes available to help decrease medication errors from occurring. Want to go quickly to drug shortages. We all see drug shortages as daily events in our hospitals, and that also increases the potential for medication errors. One thing I really would advise against is if you get different medication supplied by different manufacturers, have your pharmacy take those out. Because by having that just, again, contributes to medication error from occurring. So what we actually do is if, we have limited supply of one manufacturer and not the other, we'll say, well, supply this in our ambulatory area or our neuro area, but keep it consistent in the different areas. Otherwise, it's another potential for error to occur. And then I want to quickly touch on, what a medication error occurs, what can happen to those of us that provide care to our patients. This particular story is really sad. This is a nurse who inadvertently had given a newborn the wrong dose of medication and felt the guilt and the weight of that, and tragically took her life. And so peer support is a very important part of that, and having peer support mechanisms when a medication error occurs. This particular case received a lot of publicity, and this was the criminalization of a medication error. And this was the case of Charlene Murphy, who was a patient at a large academic center. She was in a Neuro site, and inadvertently, the nurse there had not normally worked at that site, in that Neuro site. She had an observer with her. She had never given midazolam or vecuronium before. She typed in 2 letters into her automatic dispensing system, VE, thinking she was getting Versed, and got vecuronium and mixed it up. There was no monitoring for this patient, and the patient died. Nurse Fott was then convicted of gross neglect and then sentenced. And the thought process was, should a healthcare professional be sentenced when there was no intent to harm? And APSF formed a task force and really said that by criminalizing medical error, you don't decrease it. You actually, decrease the incidence of reporting and decrease the incidence of having a safe space. And really the focus should be on peer support and education rather than criminalization of the healthcare professional. One aspect that Dr. Greenberg will talk about is some of our patient safety priorities. And so one of them is the medication safety patient priority group. And this group has actually formed these recommendations and working on developing more content for not only those of us here in the U.S., but internationally. Medication safety is even more of an issue, where there are no color-coded labels, where they actually use color-coded ribbons because they believe in color and don't have the resources to have labels. And so just wanted to share some of that with you as well. And so just final thoughts, in your area of practice, if you don't have a pharmacy anesthesia work group, I really highly encourage you to consider either starting one or developing one. We work very closely with pharmacy on many issues in terms of medication safety, drug diversion and such, and it really helps create a safer environment for our patients. Always use the generic name if you can, because by just having that, not only in how you communicate that, but also in your dispensing systems if you have automatic dispensing systems, because it decreases the incidence of an error by half. Since that time at that large academic center, where previously they could input only 2 letters, they have to now input 5, and only generics are used there. and then recognize both in the neuro locations and then when pediatric locations, the incidence of an error is increased. Pediatrics, obviously, because of the decrease of therapeutic index for these patients, and then neuro just because of the variability. And then lastly, at your institutions, advocate for peer support. If you have any questions, please, my name and email address are there. Thank you. Oh, one last thing. Want to also encourage you all to attend the ASA meeting in San Antonio in October of this year. Thank you.